a lot of work with the RECGP around quality improvement and looking at ways that we can improve care delivery, and also have a diploma of management, training and assessment, and a graduate certificate in chronic disease self-management advisor. So my absolute core passion is certainly chronic disease management and health promotion, and really improving those efficiencies within that general practice setting. Improving those efficiencies for the general practitioner, for the nurse, receptionist, and most importantly, to improve that patient outcome. So the outcomes that we're hoping to achieve from tonight's webinar is to develop an improved understanding of some MBS item numbers around health assessments, to discover how we can adopt a business model to support preventative care, and discuss collaborative care and where the practice nurse fits into care delivery. The company that I've set up, CD Program Development, our key message is that you can increase profit without compromising care. So the business side of general practice, we can't get away from that. It is, in most cases, a business, but you can certainly work on that business profitability, but also look to, improve that patient outcome. And what does it take to get the patient off the couch into the general practice, through the general practice, some really intentional care strategies, then back out the end and be better for it. So a couple of things before we start. You'll see this little image come up with compliance rules, regulations, and guidelines. Because we are talking around Medicare, and it's really important to keep general practitioners safe, anything that has that image on it, a page with that image, it's pretty much been cut and pasted from mbsonline.gov.au, because they're the kinds of rules and regulations that it's really important to convey to you exactly what Medicare is saying. So we haven't taken what Medicare is saying and changed it or glamorized it or made it more attractive. This is what Medicare says. So it's really important for GPs to keep them safe in that billing area. If you see there, here's a tip, post it. That means that's something that you can try in your general practice. So in the 8 years that I've been doing this across the country, we've picked up a few tips and tricks along the way. So there for you to be able to take back and maybe implement tomorrow when you go back to work. There's also the frequently asked questions image. So if you see this on a slide, that means it's a regular question that we get a lot. And so it's an important point worth talking through, because it gets raised a lot, and you'll see that as we go through. So let's get started. I know your time is precious. It's evening, so we'll get going. So there's no secret in prevention is the key to Australia's health future. We know that preventative care is going to reduce a lot of heart disease, cancers, through things such as healthy diet, physical activity, reducing smoking and alcohol. And health assessments play a really important role in that preventative health care. And so the Department of Health, in its wisdom, has developed 4 time-based MBS item numbers to support general practice in delivering that preventative care. There's 7 target groups that those health assessments are aimed at. There's also the Aboriginal and Torres Strait Islander people. And we'll go through all of those things for you this evening. And so just some background information, because I always think this is really interesting. So between July 2017 and May 2018, which is the latest statistics, there was over 10 million general attendance MBS items in Western Australia. Seems like a lot, but Western Australia is a massive state. You've got a big population there, and that's the work that's being done. And that's just general attendance MBS item numbers. But interestingly, 103,000 of those were health assessment MBS items, which equates to about 10.9% of attendance for health assessments. I hear a lot from general practitioners across the country that we're overdoing health assessments. We do too much chronic disease management, but the figures just don't support that claim. There's a lot of work to be done in health assessments and chronic disease management. And if you're fortunate and willing enough to join us next week for the next webinar, we've got these same sort of stats around chronic disease management, and it's telling a very similar story. We're not doing a lot of these things. We're not overdoing them, where it's 10% of Western Australia's billings for health assessments, which isn't great. So before we start, our primary responsibility is to look after you, the GP. And so it would be remiss of me not to put this slide in, that under the Health Insurance Act, GPs are legally responsible for services billed to Medicare under your Medicare provider number or in your name. So it's really important that, MBS item numbers that are billed through your practice, whether you're in a group practice or a solo practitioner, that you're ultimately responsible for that item number. A lot of the times I hear GPs saying, oh, the receptionist just take care of that, the receptionist just do that, or the nurse does that. But it's a real responsibility to know what you're billing, to make sure that it's Medicare compliant, that it's crossing the T's, dotting the I's, and that you're safe. What we don't want to have happen is that you get lulled into billing item numbers that you're not familiar with, because ultimately it's your responsibility. So tonight's webinar and next week's is around protecting GPs, giving them the information that they can confidently go and do these health assessments and care plans and mental health care plans, that kind of thing. But let's crack on to health assessments. So again, you can see here there's a frequently asked question image and the compliance rules, regulations and guidelines. So this is straight from the horse's mouth, mbsonline.gov.au. And these questions here constantly comes up with, what is a patient's regular doctor? And MBS says a health assessment should generally be undertaken by the patient's usual doctor. Now, your usual doctor is your usual doctor who you might see, but if you're a GP working in a practice that has multiple GPs, then that also extends to all the GPs working within that practice. So, practices are changing now where a patient may be a patient of a practice and not so much the patient of a particular GP within a practice. So who is their regular GP? It's either the specific GP or a GP of that practice, if that helps you as well. And practice nurses or Aboriginal health practitioners can assist general practitioners in performing these health assessments. And then again, it's straight from Medicare. Now, we've talked about those 4 MBS item numbers for health assessments. So there's a brief health assessment, which is MBS item number 701, which is essentially an item number for a health assessment that takes less than 30 minutes to complete. And again, that is GP plus nurse time combined. So the nurse may have spent 20 minutes of that time with the patient, and the GP may have spent 5 minutes, which equals 25 minutes. So therefore you'd bill a 701. Or the GP alone may have only spent 20 minutes. So then again, that's at 701. So it's really important to remember that it's that combined time. Then there's a standard health assessment, which is MBS item number 703. And that's a health assessment that takes between 30 and 45 minutes. Again, it's that combined time. There's a long health assessment, which is MBS item 705, which is a health assessment that lasts at least 45 minutes, but less than 60 minutes. And looking at MBS statistics, that's the most utilised MBS item number for health assessments. And then, of course, we have the prolonged health assessment, which is an item number 707. And this is for a health assessment that has taken longer than 60 minutes. Now, reading through Medicare, there is no there's no guidelines as that if you're doing a certain health assessment, it should take a certain amount of time. How long it takes is up to the GP who is ultimately billing that item number to decide using their discretion. So you might have a health assessment that's 1 page long, that's quite brief, but you feel that you still met that criteria, but it took 20 minutes, then it's a 701. Or you might have a health assessment that, heaven forbid, is 10 pages long. It's taken you 65 minutes to get through. I mean, it might be just the GP or the GP and the nurse, and then by all means you bill a 707. So how you choose to spend that time is completely up to you, but there it must fall in between that 701, 3, 5, and 7 time frame to make it work. So a health assessment means the assessment of the patient's physical, health, psychological, social, all of those things. It's the whole patient, the health assessment. Education could be offered to the patient, and it's all around improving the patient's health, physical, psychological, social function. So the whole goal of this health assessment is, let's do a head-to-toe health assessment, taking into account, the whole of patient experience, and then taking that information and going, well, what did we learn from that, and what can we give you to support you moving forward from there? Is it some information about diet and exercise? Is it information maybe around medication compliance? Is it information around, screening opportunities, bowel screening opportunities that are coming up? So it's kind of those things that you've looked at them, you've gathered that information, and what are we going to do with that information? And then you take that forward. But really important, this is a whole of patient health assessment. So rules and regulations from mbsonline.gov.au is before a health assessment is commenced, the patient and or carer or representatives, if that's required, must be given an explanation of the health assessment process and its likely benefits. Now, I underline must because that's the word that mbsonline.gov.au has chosen to use. So that's kind of their shouty must-do language. It's a must. The patient must be asked whether he or she consents to the health assessment being performed, and consent to the health assessment must be noted in the patient's records. That's a huge area, just that last sentence, that doesn't routinely happen. Patient comes in, we'll do a health assessment, spit out a form, and off we go. But then where's that consent been documented either on the template, in the patient's medical records? And that really needs to be done because it's the rules and regulations around Medicare. So here's a tip: create a shortcut. So most electronic health records, Medical Director, Best Practice, I think Communicare, ZMed, Genie, these kinds of platforms will have the function that you can create a shortcut or an autofill. And so what you can do is you might be able to create a shortcut, and the nurse could do it. So you could create a shortcut that's open to everyone in the practice, and it'll come up and you'll create it saying, patient attended today for a health assessment. Explanation provided about the process and the benefits. Patient has given the verbal consent for this health assessment. And you might call that shortcut HA1. So as soon as you type in HA1 space, that paragraph would automatically pop up into the progress notes. And then you can say, well, there's our proof, or there's our documentation that consent has been given. So it's a really quick, you create a shortcut once, it stays in the medical software. You might want to consider, if you start creating a lot of shortcuts, having, a laminated card that sits beside the screen in the consult rooms with a list of the shortcuts. HA1 equals health assessment consent. CP1 equals care plan, consent. So you can create these shortcuts that the whole of the clinic can use. Alternatively, you can actually put that into the template if you use a health assessment template. All your electronic health record platforms will allow you to edit or modify existing templates. It's a very easy process. Open the template, modify it, and you might add this paragraph at the top of the template, at the bottom of the template, somewhere that you've got documented that the patient has provided consent to that health assessment. It's just one of those things that, if Medicare was to come and for whatever reason review the practice or do an audit, at least you can tick off, yes, we have documented that the patient has given consent. And it's a really easy way to do it, either by the shortcut or add it as part of the template. So you can try those things. Now, rules and regulations again. A health assessment must include the following elements. So information collection, including taking a patient history, arranging any examinations. So that might be pathology, x-ray, spirometry, all those kinds of things as required. It means making an overall assessment of the patient. So I've gathered this information. What's the story telling us? And from that story, what are we going to do from there? What are some appropriate interventions? And then providing advice and information to the patient. And so that information, advice could be, a flyer on eating healthy, or an exercise program, the local gym membership. It could be anything depending on that patient, But those are things that must be part of your health assessment. So you also need to keep a record of the health assessment and offering the patient a written report about the health assessment. There's no regulation that says the patient must take a copy, but they must be offered a copy. Whether they take one or not, it's completely up to the patient to decide. 9 times out of 10, they don't, but they might prefer just to take the information, the diet and exercise, smoking cessation, safe drinking limits, those kinds of things, or they may decide to take the whole health assessment. You need to offer the patient's carer, if appropriate, the patient agrees, of course, a copy of the report or extracts of the report relevant to the carer. So this is all information around, it's patients, engagement. It's getting them into the process and then sharing the whole process with them, which is really important. Now we're going to the target groups. So the target groups,
Sorry, just jumping in at this point, just going back to that consent. I've just noticed a question from one of the participants about that consent, whether it should be written or verbal consent. Would you be happy to respond to that?
No, absolutely. And please feel free to jump in with questions. It can be written or verbal. So a lot of the times we think that we have to print off the document, have the patient sign it and scan it back in. But if you can document that the patient has attended today and verbal consent was provided by the patient, then that meets that Medicare requirement as well. It's kind of just addressing that consent has taken place. And it certainly doesn't require that printing off, signing and scanning back in. So I hope I've answered that, but if not, please feel free to send another question through. And I don't know if you can see, I've got this, the Mac wheel of doom has come up on my PowerPoint there. So we'll keep, it's kind of frozen my screen. So I think my computer's going to not be happy at the moment. Ouch. There we go. So stick with me, guys. We'll get this fixed up. It's time for a new computer. So it is a really important question.
Donna, while you're doing that, you might be, as you're firing up your PowerPoint again, you might be able to respond to this question. Somebody is asking, why do a 701, considering the $59.35 rebate, which is attached to it, when you could do 20 minutes and charge item number 36, more money, less hassle is the quote.
A lot of practices will have that. Very rarely do I see a 701 performed, and that's part of that reason that I find it difficult that you can do a comprehensive health assessment in that under 30-minute time frame. But a lot of practices, for whatever reason, kind of put these parameters on their work that we want to be doing health assessments. We should be doing this. We should be doing that. And then GPs will do them themselves because they don't have the nursing support. They don't have the resources to do that. So I'll just go, look, I'll do a 701. I've looked at the breakdown dollar value of the health assessments. I know that's very sad, but the bang for your buck is a 703 or a 707. They're the ones that it's, the time spent, you're getting the money back. But as to why you would not do a 36 and do a 701, it would make no sense to me to build a lesser item number if I was to put my business hat on. But I don't advocate for billing a 701 at all. It just financially doesn't make much sense at all. But it is an interesting question. And look, if you've got more questions around those finances and those specifics, I'm more than happy to go through them. If you want some more information about the financial specifics, send that information through or email Beth, and I'm happy then to answer those questions around those finances and to send them through. So I'm more than happy to do that. Carer. Oh my God, now it's not working again. Gets to the same slide and it's stuck. Ah, dear, oh dear. Are there any other questions at all, Beth, while my computer's trying to work?
Sure, I will read this one to you.
Yeah.
Can you please discuss when a patient comes and they have a range of issues, and good practice shows that the patient is eligible for a health assessment or diabetic risk assessment, but if the patient is new to the doctor and the clinic, can we do a health assessment or send the patient to his own GP for the same? Again, how many visits can she do when he comes as a regular patient of the clinic?
Yeah.
Sorry, I'm not too sure if I got that last sentence correct.
No, I think I understand. So, and this question comes up a lot of, when do they become our patients as opposed to the other clinic's patients? When can we say that they're ours? And so I always say, if the patient has turned up to the clinic and said, this is my clinic, this is where I want to be, then they're yours. Especially if they filled in a new patient registration, they want transfer of records, then you could confidently say that they've, transitioned from their previous practice to yours. And I would also just suggest that if a patient comes to you and says, I need a health assessment, I'm only new, I've only been here, 1 or 2 visits, but I intend to make this clinic my new clinic home, then I would do a health assessment. Interestingly enough, and this is an MBS, one of those little glitches within the system, if you have a patient come and they may have had a health assessment done at a previous practice, if they come to you and you do a health assessment and you bill it, it will go through Medicare and they will pay it. I don't know if it's because there's those 701, 3, 5, and 7, and they may have billed a 705 and you've now billed a 707. So as far as Medicare is concerned, they're not conflicting item numbers. They're 2 separate item numbers. Medicare doesn't know if that patient falls into the category where they might be able to have a health assessment every 3 years, which is the 40 to 49-year-old health check. And so they're not privy to that information. So they will actually pay the health assessment. Now, I've spoken to lots of GPs over the last 8 years around this health assessment question. It does come up often. And I think it's safe to say that the majority of GPs say that if a patient has come to us, I haven't done their previous health assessment, I'm not privy to that information, I don't have those lab results, I don't have that history, I don't have the specialist letters, I don't have any of that information. So for me to do a health assessment makes sense because this patient's new to this clinic. This is a new health assessment that we are doing as a clinic. So they feel quite justified then in doing that health assessment and billing it, even if the patient says I may have had one at a previous clinic. And interestingly, patients never know quite what they've had before, which is always a bit sad too. So I'm hoping that answers the question. There's no real hard and fast rule other than, has this patient identified that you're their general practice now? I hope that makes sense. And I think I'm going to have to turn my computer.
Donna, what we can do, we'll switch to, I'll bring up the PowerPoint on my screen, and so if everybody just gives us 2 ticks, and I'll get that sorted shortly.
Yeah, my apologies. I think maybe it's running PowerPoint and it's got the go-to webinar at the same time, and it's just not liking it. So if we do that for you, and then we'll be able to just pick up and keep moving on. Again, my sincere apologies. If you're still sticking with us, guys.
Yeah, all right. So I'm hoping that everybody can see my screen now. I'm just going to flick to the PowerPoint that the slide that you were on. Just bear with me a second. Can you see that, Donna, as I'm flicking through?
Yeah, yep, absolutely. Thank you.
Great. Just remind me when to stop, where you got up to.
I will.
And as I'm doing this, actually, I'm just going to read another question to you.
Yeah.
One of our participants asks, 707 takes 1 hour of time. I find the clinic may not necessarily be willing to spend the nurse time, nor the nurse be willing or keen to spend the time. Any tips to actually tell the clinic or nurse that I want them to spend the time? They usually run through the templates very quickly, which is far short of the billable time.
That's right. A lot of that is going to come around to, and you can start it from there if you like.
Okay.
Beth. A lot of that comes around to presenting a business model to the key decision makers in the clinic. So whether that's the practice manager, the practice owner, the lead GP, whatever it is, but it's saying, well, look, here's the financial benefit from a 707. I feel like you can kind of hit them with, this is the financial benefit and this is the improved patient outcome that we're going to be doing this. And as a GP or as a nurse, whoever's posed the question, this is what I think is best practice, this is the one I do, and this is actually the financial benefit. We go on to what those figures actually look like. And the other thing to remember too with a 707, and this will come up in a couple of slides, is that if a patient comes in and has a health assessment, which is a 707, which I think is $258.68, plus or minus a few dollars. So that's quite a lot for that hour, and you've got the nurse time, but there's nothing to preclude you from doing an ECG, like a baseline ECG with that patient. Or if they're a current smoker or have a history of smoking, to add on a spirometry to that patient. And with spirometry to be billable, it requires pre and post bronchodilator. And sometimes that's tricky if patients are having difficulty with the device, with the technique. So that in itself can take 20 minutes. So all of a sudden, your hour health assessment, now an ECG might only take 5 minutes. And then you've got a 20-minute, spirometry all going to plan. So already we're up to 25 minutes, which is still part of that health assessment. And so it becomes, that $260 health assessment. Now we're adding on the ECG and adding on the spirometry. So it actually makes it quite financially profitable to when you do that health assessment and you add on these item numbers. And in my experience, a reluctance from nurses sometimes to do health assessments is that they don't have the resources or the skills to be able to do them. And you've got to remember that a lot of practice nurses, very rarely do you leave a hospital or an acute care setting or university and go straight into general practice. You've come from acute care, you've come from nursing home, this kind of thing. You find yourself in general practice and you don't have those skills necessarily to do that patient engagement. And they are skills that are learned and are certainly required to do chronic disease management and health promotion. It's quite daunting, the idea of sitting down with a patient for an hour or 45 minutes and chatting. What do we chat about? Do I have enough knowledge and expertise? What are they going to require of me? How do I actually fill 45 minutes worth of time? So a lot of resistance to do it is not that they don't want to do the work, they don't know how to do the work. So the first thing would be to develop a business model or to put some financials around it, and then maybe ask more, probe deeper as to why don't the nurses want to do health assessments. And at the end of the day, you need the right nurse for the right role. If your nurse just does not want to do them, that's probably going to reflect in the way that she does them. So maybe it's worth, another nurse doing them, or if you don't have the luxury of being able to pick and choose which nurse, it's maybe sitting down and, doing some training together and, working that kind of thing out. But we assume that, everyone should be able to know how to do this. And it's a skill, especially with chronic disease management. It's a skill to ask someone about their chronic disease and sit down. And the same with health promotion, certainly. So that would be my advice. Dig a little bit deeper and find out what the actual issues are, and then hit the practice owners with the financials. Yeah, typically that works with them. So I think we can go to the next slide, if that's okay. Are we able to go up to the slideshow at the top of the screen across from file? If you can see that up there. And go up to slideshow. So you've got file, which is an orange, home, insert, design across the top.
I'm just a little bit worried about doing that, Donna, because I might just lose some of my other controls.
Ah, okay, no, perfect, that's fine. We'll go straight into the target groups. So there are 7 specific target groups for health assessments. Now, some of these are a permanent resident of a residential aged care facility, and these are typically referred to as a CMA, or a comprehensive medical assessment. There's people with an intellectual disability, humanitarian entrants, but they need to be residents in Australia with access to Medicare services, including refugees and special humanitarian program and protection program entrants. So it's quite specific around that particular cohort. And former serving members of the Australian Defence Force, including former members of permanent and reserve forces. And depending on what software you have, there will be, I think Medical Director a couple of years ago made it as one of their program updates that they inserted this kind of health assessment into the software, specifically around that ADF. I think there's a lot of funding around that one. If you go to the next slide. Now, these are the ones here that we're really going to look at and to target on the next slide, and they are the ones that are the most typical ones in general practice, and that is the 40 to 49-year-old inclusive with a high risk of developing type 2 diabetes as determined by the Australian Type 2 Diabetes Risk Assessment Tool, or the OBV Risk Questionnaire, and there's a little image of it there. What's really important to note here that yes, this is open for patients between 40 and 49, but they have to have a high risk of developing type 2 diabetes as per the questionnaire. If this patient does the questionnaire and they don't come up with a high risk, technically they are no longer eligible for that health assessment. So a really important one to get your head around. Just because you're 40 to 49 doesn't mean you're automatically eligible for that specific health check. There is the health assessment for people aged between 45 and 49. Now that one is for patients who are at risk of developing a chronic condition, which in my calculation would be anyone aged between 45 and 49. So yes, they might look fit, you know, that's your gym junkie, the runner, you know, fit as a fiddle, but they are still at risk of developing a chronic condition. You know, we don't know what that looks like. So that's a really good health assessment that captures that population. It doesn't have the same restrictions around it as the previous health assessment. And then of course there's the over 75 health assessment, which is, as the title suggests, open to patients who are just over 75. Now these health assessments are broken down into this table here for you, and there is a recommended frequency for these, and there's different bits and pieces along the way. So the 40 to 49-year-old health check is actually eligible once every 3 years. A patient can have that health check. Age between 45 and 49, it's a once only. Age 75 or older, they can have this health check annually. And we sometimes see this done in patients' homes, or we see it done into the clinic. There is no extra rebate available if you do it in their home. It is ideal to do it in their home for this population because you're looking at their home environment. You're looking at the way they're storing their medications. Do they have tripping hazards in the home? Do they have lots of rugs and, you know, telephone cords or, you know, extension cords that are across hallways that are a tripping hazard? You know, often you'll go to these patients' home, they'll want to make you a cup of tea, and it's always a good opportunity to have a sticky beaker in the kitchen. You know, is the kitchen looking clean? Is food looking like it's kept properly? It's a really good opportunity to kind of, to look at the whole of patient, but their living environment for this age group. But again, you have to consider there's no actual financial extra benefits for actually the time out to do that. And you have to take into account that it's taking a staff member out of the clinic, they're driving to the patient's home, doing the house assessment, often writing it on a piece of paper in the template, driving back to the clinic and porting it into the patient's template. So I wouldn't suggest doing it for everyone, but for those patients who, you just want to know what's their home like, are they doing okay? It's a really valuable house assessment. Then you've got residents of an aged care facility called a Comprehensive Medical Assessment, or a CMA. Again, that's available annually. Intellectual disability is annually. Humanitarian entrance, it's a once-only health assessment. And former serving members of the Australian Defence Force, again, it's a once-only health assessment. If you could get really organised, and I've never seen a clinic able to do that, you could do a health check at 40, then you could do one at 44, then you could do another one at 47 or 48. It would take a lot of structure and processes in the clinic to do that. And I really haven't seen that happen in the 8 years that I've been doing this. Often there's enough patient population that you're so busy keeping up with the work that's there without trying to fit in and health assessment every 3 years. And sometimes patients aren't all that keen to have that done. So here's a tip: search your database. So most of your platforms will have the function to perform specific searches. And if you don't have that search facility or functionality within the platform, I'm pretty sure Rural Health West, I think, or the WAFA in WA supports the PEN data extraction tool, or it'll be something similar, whether it's Polar or a canning tool. But there's a data extraction tool that will be quite readily used in WA. And those tools can usually get into your data at a more granular level. But my idea is to go in and go, well, who are our patient population? Another tip, because the 40 to 49-year-old at risk of developing diabetes patients have to have that OSD risk questionnaire, I typically break the health assessment age groups up into 40 to 44, because they're the ones that need that health assessment and they need that questionnaire. And then 45 to 49, so they're a bit easier because you don't need that, that OSD risk questionnaire. And then my over 75s, and I typically break it up like that. And then what I would do from there is you've got to bear in mind that your 49-year-olds, once they turn 50, they're no longer eligible for a health assessment until they're 75, unless they fit into those other criteria, which is quite a long time. So if you're looking at your patient population, you've got to take into account what resources you have. If you've got one nurse or a large practice, maybe just focus on your 49-year-olds before they drop off and turn 50. So you can really capture them, and then break up your 40 to 44-year-olds in that separate category. And then just to make it a little bit more exciting, if you can have access to these tools, you can actually go in and say, who's a current patient between 40 and 44 who has an increased BMI, an increased blood pressure, and a high cholesterol. So now what you're doing is you're specifically targeting patients who are probably going to score high on their OSD risk questionnaire, given their weight, blood pressure, and cholesterol status. And ultimately, they're the ones in most need of a health assessment, because left to their own devices are more likely then to develop diabetes, heart disease, or kidney disease. So again, it's just being more intentional with your patient targeting and who you're getting into the clinic. You send out an invitation to, that gym junkie who's 43, who's never smoked a day in his life, doesn't drink, goes to the gym, fit in a fiddle. He's more than likely going to ignore your invitation for a health check. That same invitation sent to the overweight, high cholesterol, high blood pressure patient is probably more likely to go, I may actually need to investigate this, and they're more likely than to come in. So it's just being a bit strategic in who you're inviting in, but just something to keep on the back of your mind. We'll go to the next slide. So, and the other thing with the 40 to 44-year-old patient population is you may, if you're still sending out letters, you may be able to send out an invitation letter with the questionnaire that they can actually fill in at home. And it may be one of those shock factors that they fill in the questionnaire and they're going along and they themselves score high. And that might be the trigger for them to go, you know what, I really should have a health check. I've filled in this questionnaire and it doesn't look great. Or have these in your waiting room. You know, you have the reception staff, patient comes in, he falls into that category. Would you mind filling in this health, this questionnaire? We're doing it for all our patients. You know, and get the patients involved and get some, engagement into their health outcomes. So I think that we've covered that here. It's really important that they need to score high on that check. And people between 45 and 49 who are at risk of developing a chronic disease. Often I get asked, if the patient already has a care plan, can I do this health assessment anyway? And my answer is, well, in my opinion, no. Nowhere in Medicare does it say that they can't, but we're screening for patients who are at risk of developing a chronic condition. If they already have a chronic condition, then we already know about it. So it begs the question, why then are we doing a health assessment? But again, it's something worth considering within your practice. And again, work backwards. Start with the 49-year-olds before they turn 50. We'll soldier on with that one. Now, the Aboriginal and Torres Strait Islander health checks. Now, these are a great health check. I'm not sure how many of you are engaged in Aboriginal and Torres Strait Islander health. Do a lot of work in WA in Aboriginal medical services. Currently doing quite a bit of work in Port Hedland and spent 2 years working with Swams and Bunbury. So really getting a lot of experience and traction around this Aboriginal and Torres Strait Islander health. So we'll go to the next slide for that one. Now, the Aboriginal and Torres Strait Islander, there is a lot of compliance rules, regulations and guidelines around this. And again, this is the same as the previous disclaimer, that it should be taken by the patient's usual doctor. And by that, it's a usual doctor or doctor within their usual medical centre. And again, the practice nurse or Aboriginal health practitioner may assist the general practitioner in performing health assessments. We'll go to the next slide. Now, this health assessment, unlike the other health assessments, are open to all age groups from birth until death. So an Aboriginal and Torres Strait Islander child of less than 15 years, then an Aboriginal and Torres Strait Islander who is between 15 and 45, and then 55 years and over. So there's no exclusion. There's for these particular health checks. They're open to everyone of Aboriginal and Torres Strait Islander descent. Something that I haven't put into the slides, but it's worth mentioning, is that if a patient comes to your clinic and self-declares as an Aboriginal or Torres Strait Islander, that's all you need to have to be able to then go on and to notate that patient file as an Aboriginal or Torres Strait Islander, to that PBS script notation to do these health assessments. Nowhere do you need to ask for proof or any of those things. It's if they say they are, then they are. And that's how it works in general practice. Full stop. We'll move on. So the health assessment must include the following elements. And again, it's an information collection, an overall assessment, recommending appropriate interventions and providing advice and information. So again, it's the same theme of health assessments across the board. But then where it gets tricky with the Aboriginal and Torres Strait Islander ones is it's quite specific breakdown in those 3 age categories. We'll move forward. Interestingly, the health assessments for Aboriginal and Torres Strait Islander may be provided every 9 months. So it's not every 12 months, but it's every 9 months. If an Aboriginal and Torres Strait Islander patient, say, might be 45, it is recommended in mbsonline.gov.au that they have item number 715, which is your Aboriginal health assessment, and not your 701, 3, 5 or 7. They actually want it attributable to that 715 Aboriginal health check item number. It's a slightly less value. I think it's $212 from memory for that health check. So slightly less than the others, but then it's annually. Well, it's every 9 months that you can do that. So that's where the trade-off is. And it's also really important that the more data and statistics that we can actually have, then we know what's happening in general practice. So if we don't bill the appropriate item number, it's going to reflect in the statistics. So we're going to say we didn't do as many Aboriginal and Torres Strait Islander health checks. We may have, we just billed them differently. So they really need to be that 715 item number. And you can simply recall these for 9 months. We'll go on to the next slide. Now, the must-haves for Aboriginal and Torres Strait Islander are very comprehensive, very, very comprehensive. So I would suggest going to mbsonline.gov.au, enter MBS item 715, and you'll get the detailed description and breakdown for each of those 3 categories. So the 0 to 15, the 15 to 54, and the 55 and over. For example, the child one goes into the birth experience, the feeding, their eyesight, those kinds of things. The adult one talks a lot around, the smoking and alcohol, sexually transmitted diseases, those kinds of things. And the older one, looks into that falls risk, and all those things age-related. So they're very quite specific on what they must have. And if I was to put them in the slides, we'd be here till midnight, and I'm sure you don't want to be here that long, but really important to go to the website and get those. But you'll find that in most clinical software, there'll be a template for those health assessments. Now, if a patient does come in and have an Aboriginal or Torres Strait Islander health check, they are eligible for follow-up allied healthcare services as part of the outcomes from the health assessment. So the GP can refer up to 5 services in total per calendar year. This is the same services that the patients are eligible for post-care plan or post-GP management plan and team care arrangement. So this is podiatry, physiotherapy, social workers, chiropractic care, all those things. This is if they have a chronic condition and they have their 715, then these patients now are eligible for 10 allied healthcare services during a 12-month calendar year. That's really great for this patient population. So a total of up to 5 services include, and that's the item numbers that are attributable to those podiatry, physio, etc. They could have one service type, like 5 for physiotherapy, or they could have a combination. So you've got your dietitian, podiatry, physiotherapy. So unlike the care plan referral where you need your GP and 2 others, here you can generate a referral and send them off for 5 Aboriginal health workers, 5 podiatry, whatever the case may be. There's a lot more flexibility around these referral processes. But bearing in mind, this means that these patients are eligible for 10 services, which is fantastic. We'll go on to the next slide. So after completing a health assessment, GPs can claim item number 10987 for follow-up services. So practice nurses and Aboriginal and Torres Strait Islander health practitioners must provide these services on behalf or under GP supervision. So you must be aware of the item number 10997, which patients can have post a care plan. Well, then we can have these post a health assessment for these patient population. They can have these appointments. They can have 10 of these in a calendar year, and they're actually worth $24. So they're worth twice as much as the 10997, which again is fantastic. Working in Aboriginal health, there's a lot of diabetic follow-up, sometimes these wound follow-up. So these patients can come in, and they might come in every day for 2 weeks. So you might use 10 of these item numbers, 10987, in a 2-week time frame, and that's okay. You can't do 2 in one day, of course, but there's nothing to preclude you from doing a 10987 Monday to Friday 1 week, Monday to Friday the next week. Once you get to number 11, it's going to be rejected from Medicare, but you can certainly bill 10 of those in quite quick succession, claim them, and it kind of helps offset that cost around, that wound material or diabetes follow-up, all sorts of things. So that's a really great item number for that patient population. And for bulk bill claims, those 10990 or 10991 also apply as well. So then all of a sudden these item numbers, you can get quite a list of item numbers for this patient population. We'll go through to the next slide. Really important, the referral form for this form looks the same as the referral form for a team care arrangement, but it's not the same. So the item numbers are slightly different for the referrals for the podiatrist. So it's really important to have a look in the software and to make sure that you're using the right form, because they look identical, but there's slightly different numbers involved. Now, if you want to know where you can find that form, there's a link there, but that's exactly where it is for you. If we go to the next slide. Here's another tip. Now, I don't know if the GPs that I'm talking to now, if you're new to the general practices that you're working in, or nurses are new to the practices where you're working, but sometimes it can be an absolute minefield looking through documents and templates to find the document or the template that you're looking for. And it'll often be, oh, that's an old one, or they're named really, weird, and you can't find these. Really simple is to go through or have the practice manager or a nurse or, collaborate on who's going to do this and rename your documents to make it really easy to find. So you might want to call all your health checks, health check dot, 40 to 49, 45 to 49, over 75, ATSI child, ATSI adult, ATSI older adult. So then what you're doing is, instead of just going through all these different templates, you're going to health assessments. It's all in alphabetical order. You get to your health assessments and it's just clearly laid out which one you're after. You can also do that with your referral forms. They're the ones that we had on the previous screen. So you might want to call it referral form dot 715 Allied Health or referral form dot TCA GPMP. So again, it makes it really simple to find these forms. You save an enormous amount of time finding these forms, and it makes it really simple for new GPs or new nurses, allied health, receptionists, whoever it may be, coming to the practice to actually find these forms. It's a really quick task. You just rename them, and it saves so much time. Certainly don't recommend you delete any forms, because the minute you delete a form, there'll be someone in the practice and that was their favorite form and you've deleted it. Typically, if you put a Z, if you rename it, and it might be Bob's health care plan and Bob left, you can put a Z in front of it, and because it's all alphabetical, it'll drop it to the bottom of the list. So it's still sitting there, but you kind of just put it in the bottom, and it keeps it out of the way. So then you keep your relative forms quite clean and easy to look for. So again, something that you can take back tomorrow and implement in your clinic. We'll go to the next slide. Oh, square pegs and round holes. Now, I know that we're run short of time, and that is technical error, so we'll get through this as much as we can. I'm happy to finish if you're happy to stay online, so we'll keep going. Now, not all our patients are going to fit into those categories. You're going to have a non-Indigenous client who's 52. They're just not going to fit into those categories for a health assessment. We'll go to the next slide. So often what happens is we don't do anything. We go, look, it's too hard, they're not eligible, too bad, so sorry. So what do? It's like, well, we can still provide a health assessment for this patient. There's nothing to say that we can't do that. So what are our options? We can actually do a longer appointment. So as a GP, you might say, I might do that extended appointment. If it's a bulk billed clinic, then you're simply billing the higher item number, that higher rebate. If it's a private clinic, you could consider billing a higher valued item number, but bulk billing it in that circumstance because it's for a health assessment. So you're still getting some financial return, you're offering a good service to the patient, and you're providing that health assessment. Some clinics do a modified health assessment template. So it's quite a short template. It's not as lengthy as the one that you would use perhaps for 707 or those item numbers, but it might be one that, we've got 20 minutes is all we have. So let's modify this health assessment template so we can at least provide something for the patient. But also remember that you can add on your ECGs, your Doppler and your spirometry, which again just boost those item numbers and put some more value into it. So all of a sudden it's making it quite a worthwhile time for the GP, for the practice, to be able to provide these services. So don't stop offering care to these patients because they fall outside that category. Just maybe think more laterally. It's like, well, as a clinic, what can we do? Can we do a shorter template? Can we bulk bill that as a dearer item number? Or, you know, let's work out how we can do that. So next slide. So don't give it away. A lot of services delivered in general practice are not billed, due mainly to uncertainty around eligibility or their poor processes. So try sharing the knowledge that you learn around MBS with the clinic team. Sit down and go, this is what I picked up around health assessments. I think we can do this. Let's target our 49-year-olds. You know, did you know that this is the eligibility criteria? This is what Medicare says, and share that information. In my experience, a lot of GPs won't bill for the work that they do because they're not sure of the item number. And so their knee-jerk reaction is, we won't bill it, or I'll pick it up next time. You know, you're doing the work, you deserve to be paid for it, but share that knowledge within the practice, you know, and get everyone on board, and so that everyone knows what they're doing, and then it kind of creates that atmosphere, you know, that safe environment. We'll go next slide. Did someone say nurse? So nurses are a huge asset to general practice. They play a really important role. You know, like we touched on earlier, it has to be the right nurse for the right role, but practice nurses can do a lot of the work in general practice around health assessments. You know, we can do a lot of the, you know, the information collecting, the height, weight, blood pressure, you know, BMI. We can offer that advice on nutrition, exercise, you know, and really get in there. And if they've got the right skills and the resources, can make it a really worthwhile appointment. We understand that GPs are time poor, so then let's put some of that work onto nurses and make it a really worthwhile experience for everyone on board. We'll go to the next slide. So then practice nurse role in providing health assessments, and, you know, like I was saying, it's documentation, updating medical history, taking measurements, checking medication use compliance is huge. A lot of the times, you know, the patient will see a GP, and being a nurse, my background, and doing a whole lot of care plans and health assessments, patients will say, I didn't tell the GP, but I don't understand what that medication's for. I didn't want to say anything because he's really busy. I didn't want to say anything because I'm going to look silly. But patients will open up to nurses around some of that information that they won't talk to their GP about. They might come and see a nurse, like a female might come and see a female nurse, and so when was their last pap smear? When was this? You know, what's happening in their, you know, in their body that they wouldn't necessarily open up to a GP about. But also I've had lots of experiences where male patients have opened up to me around, you know, sexual dysfunction, prostate. You know, we've been talking about family history, and yes, I am having problems there. It is stop-start. I don't feel like I'm voiding my whole bladder because it's in that very relaxed atmosphere. They don't feel rushed. Patients always feel like they're taking up too much of the GP time. So nurses can really contribute a lot to that and do a lot of that work for you. We'll go to the next slide. So really important to remember that the nurse and the GP time are combined to determine the appropriate health assessment item number. So put them all together, except of course item number 715, which is the Aboriginal and Torres Strait Islander. That is not time-based at all, that health assessment. And you can also do those ECGs, spirometers, and Doppler, that kind of thing. Go to the next slide. So here's another tip. Create a safe environment within your workplace. One of these things here is, you might say, as a general practice, we think it's okay, we're all comfortable with each patient having a baseline ECG every 12 months as either part of their over 75 health check, part of their care plan, part of their, you know, their health assessment when they come in. We're going to do an ECG for them, or we're going to do a spirometry if they're a current smoker or have a history of smoking. The nurse might go through pathology results and go, they haven't had cholesterol done in a while, they haven't had this, they haven't had that, and may suggest pathology for a GP to print out. these nurses in general practice, sometimes have the skills and the availability, the time to do some of these tasks. But by creating a safe environment, you're saying, as a practice, we're going to support the team in being able to do this kind of work autonomously. So the nurse doesn't have to check with the GP every time they want to do an ECG. You may create a base understanding of when an ECG is appropriate, what bloods are appropriate. Can they initiate a home medication referral for a patient? Now, they've chatted with the patient around their medications. They've picked up they're not really compliant. There's some misunderstanding around their medications. Talk about a HMR, and generate that referral for the GP to sign. So again, it's, sharing that information as a clinic, deciding what are you comfortable with doing. And once you create that safety, then it kind of increases each person's role, their sense of autonomy, their clinical skills. It's a really important factor to do with your nurses. We'll go to the next slide. The really important bits to remember: prevention is the key to Australia's future health. MBS has funded item numbers to enable GPs to do health assessments. They're there, but they come with rules and regulations, and you need to get familiar with them. Remembering that the GP is ultimately responsible for the item numbers that you bill. It's not reception's responsibility. It's not the practice nurse responsibility. It's the GP's responsibility. So you have to know what you're billing and that it's safe for you. Look out for the square pegs, because they deserve your care too, and then we can work around how we provide care for them. If you've delivered a service, bill for the service. It seems a little bit silly to do a whole lot of work for nothing. If you do the work, bill for the work. And as a GP, again, you are legally responsible for the services billed to Medicare. You need to get to know them. And just trusting the receptionist, trusting the nurse, that's all good and well. It's not going to fly when there's been errors in medication or errors in MBS billing. I've seen it time and time again in practices where we've got the best practice manager. She knows everything about MBS, and sometimes they don't know everything about MBS. There's that saying, you don't know what you don't know. So just really get on board and see what you're billing and make sure that you're comfortable with that. So really important bits to remember. And the last slide. I'm so glad that you could bear with us, and I apologise that we've gone over. There was that technical glitch, which I will fix up in time for next week's webinar. But if you do have the availability, I would love for you to join us next week. It's chronic disease management and mental health care plans. And again, what MBS items and when. So it's Wednesday, the 8th of August. It's the same time for you guys, 7 till 8. There's the registration link, or please just get in contact with Beth. I know that she can send that through to you. If you have questions for me, it's admin@cdpd.com.au. I'm happy to answer your questions. Send them through, whether it's around some of that business modelling, that question of raised, well, how can I convince people to that the 707 is worthwhile? We can look at some of those, the billings that are attached to that, look at some scenarios. If you do send through some questions, we're happy to maybe spend 5 minutes at the beginning of that webinar next week to go through some of the questions that we get through the week, just to tie them up. And again, I apologise for the errors, but yes, love to have you back.
Thank you, Donna, and thank you to everyone for hanging around just for that little bit longer than our allotted hour. If you do want to sign off now, I note that a lot of you who have registered for the evening have signed on for next week too, so we look forward to you joining us again. Donna and I might just hang around online just for a couple of minutes more now, if that's okay, Donna, because there is one question here that I just wanted to put to you. So, yeah. Everybody welcome to sign off if you need to, but we'll just keep it going for a couple of minutes with some questions. So, Donna, the question that I have here goes back to the Aboriginal health assessments, and one of our participants asks, can you do both the Aboriginal health check and GP MP team care arrangement? I think I've got that correctly.
Yes, you do. Yes, so a patient can have a health assessment and a GP management plan or team care arrangement. And you actually bill for all of those things at the same time if you've done the work at the same time. You can absolutely bill all of that together. Now, we know with Aboriginal and Torres Strait Islander health, some of the, the issues are getting patients to come back. And so a lot of work that we do in Aboriginal health is that opportunistic, work. So you've got a patient that's turned up, they're keen, they're engaged for that moment, and you really want to get as much work done as you can. So if you do a care plan, a team care arrangement, and your 715, you'd end up billing a 721, 723, 715, 10987, maybe if a nurse was Aboriginal health practitioner was involved, your ECGs or your Dopplers or your point of care testing. So it does end up looking like quite a large range of item numbers, but that's okay, and it is Medicare eligible to do those things at the same time. And then you could even refer, that's their 10 allied healthcare referrals then as well. So it's, yeah, very easily done. Is there any other question, Beth? I'm happy to hang around if there's any more questions too.
No, I think that might be a wrap for this evening. I can't see any more coming through. So that being the case, I might close off the webinar. So have a good evening, everybody. And, oh, hang on a minute. There might be one coming through. Lucky last, maybe. Okay, I think we're done. So as Donna said earlier, if you do have a question, oh, here we go. Here it is. Can we do the same with non-original patient, like after health assessment, can we do a care plan and bill altogether?
Yes. Yes, you can. But what's really important, unlike the Aboriginal and Torres Strait Islander health assessment, is that the non-Indigenous health assessments are time-based. So you need to consider how much time of that appointment was spent doing the health assessment and how much time of that appointment was spent doing the care plan, if that makes sense. Because you still need to bill the health assessment as a time-based service. So you might have seen the patient for an hour doing both, but how much time do you spend on the health assessment? You might say, I might have spent 45 minutes on that, in which case you bill a 705 plus your 721, 723, etc., etc. So there's no time restrictions on the care plan, but there still remains that time restriction on the health assessment.
Okay, thank you, Donna. All right, everyone, I think we will close it off there. And good evening to all, and hopefully have most of you online again next week. Thank you.
See you then.